Við þökkum Barry og Shirin fyrir þetta. Ég ætla að bjóða þeim Barry, Shirin, Markus og Önnu og Indriða að vera með mér hérna í smá pallborðsumræðum sem sér stað hér. Við höfum fengið til liðs okkur í þetta samtal Indriði Benediktsson sem sérfræðingur í stefnumótun hjá Evrópusambandinu og Önnu Sigríði Islind sem prófessor við tölvunarfræðideild Háskólans í Reykjavík. En við ætlum að eiga þetta samtal á ensku. We've already gotten to know Markus, Shirin and Barry, and I would like Indriði and Anna maybe to tell us a little bit what they have been doing in healthcare and innovation just to start with.
So this is supposed to be in English, even though I'm from here originally. I'm not sure if I could do it in Icelandic. It would be a challenge anyhow. Thanks a lot to the organizers for inviting me here on a very short notice. And also, of course, thanks to the political leadership of Alma and Logi for allowing this to happen. That's really important because now is the time for things to really happen. As of my background, I studied molecular biology and graduated with a molecular genetics degree from the Freie Universität in Berlin. I started when the wall was still there to keep us inside West Berlin, but when I left, the wall had gone, and that has been very much the focus of my work ever since, to break down walls. After a short stint at the Institute for Experimental Pathology at Keldur in Iceland, I was hired as a policy officer for the European Commission in Brussels. Initially, I was managing collaborations in life sciences under the framework programs, followed by focus on international cooperation in health research. And now, since about 10 years, I've been taking care of programs and policy initiatives in personalized medicine. So my work has been focused on linking different kinds of players in different places, breaking silos, joining forces, and creating something new. This is also very much what has already been mentioned in the previous talks. That is making something new from what we have by linking different things. All for the benefit of improved health, ensuring the use of the good research output, translating the research into real practice. And I just want to mention one example. That is the example of rare diseases. We set up a collaboration called IRDIRC, International Rare Diseases Research Consortium, in 2010 to address the fragmentation at local and global level in rare diseases. We had the situation, and it is not so long ago, 15 years ago, we were facing the situation where some of the diseases, they had different names in Latin in different countries and even in different regions. And there was no real or very little collaboration across the board. And every single rare disease was studied in isolation. And we decided to do something about it. And we had a talk with NIH back then, and they were also happy to look into what could be done to address this fragmentation. And by bringing together researchers, medics, industry, policymakers, regulators, ethical platforms, and patients, we thought that would maybe help addressing this problem. So the initial meeting of this consortium was organized between the European Commission and the National Institute of Health here in Iceland in 2010. And after that, this consortium was set up, and it has grown into a massive international endeavor, really, really international, and has really made a lot of change. It created a number of different other initiatives aimed at better serving people with rare diseases. So the landscape has drastically changed over the last 15 years. Sorry, I'm using paper and pen. I'm a bit old-fashioned. So in the case of personalized medicine, we set out to try to replicate success in previous cooperations in other areas like the rare diseases I just named. So we set up something called the International Consortium for Personalized Medicine in 2016, so almost 10 years ago. And last year we started the European Partnership for Personalized Medicine. So the International Consortium for Personalized Medicine has become the international part of that European partnership. And here the partners join forces for research and innovation funding together, for policy recommendations, for comparing different models for implementation, and to address common hurdles and find solutions. Increasingly, we are turning our attention to prevention, as has also been mentioned before here, as an important but sometimes neglected until now in health systems. When we started discussing this, there wasn't even a definition for personalized prevention or precision prevention, as you called it. So we decided to support programs to forward the understanding of what it can reach and how it can be used in the best way. And it's important to underline that personalized prevention or precision prevention is not replacing normal public health programs for prevention, like anti-smoking campaigns or drinking less alcohol or moving, because we know that sitting is the new smoking. I normally stand when I'm both when I'm speaking and also writing. Anyhow, excuse me for that. Yeah, personalized prevention, and we supported several programs that are ongoing. One is called ProFit. It's led by Italian hospital, and I encourage you to have a look at that if you're interested in their website. And they are working on a roadmap for personalized prevention. We believe that not only will prevention reduce suffering, but also rationalize the use of available healthcare funds, which, as Alma has referred to, is one of the big challenges, not only for Iceland, but for every healthcare service anywhere in the world. One example for effective personalized prevention that can be applied right now is pharmacogenomics, to maximize efficacy and minimize toxicity of medication. And here the European Medicines Agency is very interested in this subject, and we have been working with them to design some recommendations for approval of drugs in the future, but this also can be used for already existing drugs. So, working for the European Commission has not only involved interaction with European stakeholders, but in fact with the whole world. And it has included a lot of science diplomacy. On the one hand, we had extensive collaboration with more developed countries. For example, the reciprocal agreement that we made with the NIH for reciprocal funding of European and American researchers in our respective programs, applied since almost 20 years ago. And on the other hand, we also want to, we are happy to see that collaboration with less affluent countries is leading also to new things happening in those other regions. And interestingly, it has also led to collaboration between the countries in the regions. So like in Africa and Latin America. So they are starting to work together, what they did not before, because we initiated those multi-country collaborations. So this is a short overview of my work in the past years. I have been working for the European Commission for almost 30 years, until yesterday. As of today, I'm happily retired. I can do whatever I want, and I'm here to speak to you. Thank you.
Anna, hvað segir þú?
Yes. My name is Anna Islind, Anna Sigga, for all of those that know me and all of those that don't. I never answer to Anna, actually. I am a professor at the Department of Computer Science at Reykjavík University, and I have been there for the past 7 years. And it's been one hell of a ride with full swing of all kinds of things. And before that, I was 9 years in Sweden, so I was very happy with all the Swedish slides. My mission for all of those years that I have spent in academia and since I started teaching in academia has been, on the one hand, design, and on the other hand, data-driven healthcare. So I feel like I'm in the only church that I have ever wanted to belong to, right here, right now. So I feel incredibly privileged to be here in this panel. But I'm a true believer that Iceland can actually do better in terms of sharing data and having a cohesive view of data and doing something very innovative in terms of data, but also co-designing the future digital solutions together with the stakeholders. Because I think I am a true believer, obviously, because this is my church, in those two elements as the future of healthcare in Iceland. For the past years, I started up a digital health program at Reykjavík University. It was the first multidisciplinary master's program at Reykjavík University, which of course came with a lot of administrative hurdles, but it's been a true success. And we are leading together healthcare professionals on the one hand, or people with a background in healthcare, and people with a technical background on the other hand. And it's been really a great success, and actually a few of our students are in the audience. And we have also been working together with the hospital in creating an innovation program for the people working in the hospital. And in terms of the research projects that I have been involved in, they are multiple. For instance, trying to digitalize the aftercare after cancer treatment, which I was doing at Sahlgrenska Hospital in Sweden. The past years, I have been working in a huge EU project where we have been digitalizing sleep, trying to gather better data in terms of sleep health over an extended period of time with personalized data, for instance, wearables and mobile applications. So co-designing those and working with the data in a strategic way. And now more recently, we are working also with children that have anxiety, where we have co-designed a digital platform that is being used to teach parents cognitive behavioral therapy to aid with the treatment of anxiety for children. So I always work with frail users, and I always keep coming back to healthcare because obviously this is my church. Thank you.
Það heyrist alveg örugglega í mér í þessum mikrofónu. Ekki nógu vel. Þið kannski tæknimennirnir kíkja á það og ég reyni, já, þarna er ég. So, I just wanted to jump right into it and go big picture. And I think it might help frame the conversation going forward. And this question might be a little bit too simple or too complicated, but I just wanted to ask you to begin with, how do you see healthcare evolve in the coming years? What does healthcare look in 2025? Where are we going exactly? Can anyone Does anyone want to take a stab at that?
If you wouldn't have added going exactly like that last word, there's something. But there are some structural changes that will take place more or less if we want it or not, and that based on driven by demand, the complexity and increasing demand based on, as shown before, the aging population. So, and I would stress it even further that continuing as we have done and are doing now is not an option, because it won't be even equally good. It will be worse delivering and providing care in the way we have going forward, because we will not be able to meet the demand. At the same time, we want to embrace all these new opportunities, precision medicine and genetics, transcriptomics. There's so much on the radar coming in, and if you ask the population, they want to be part of that. They want, if I get cancer, I want that good modern treatment. So it's like we're kind of, you can see it, the glass half full or half empty. Either we're stuck between a rock and a hard place, like demand is increasing and expectations are increasing, or you have a half full glass and say the opportunities are the things that will resolve the problems that are increasing. And by that I mean actually restructuring the healthcare as an ecosystem completely. So we're envisioning, and hopefully I will experience, a shift in paradigm from a organization-centered healthcare to a patient-centered ecosystem of provision that is the government or the public or the payers can keep track of, because it cannot be a Wild West either. So we need to understand that in the different parts of this ecosystem are doing the right thing in its environment. And so that's, might be a bit bold, but that's the way I see it going forward.
Will that happen as a kind of an organic development of tendencies that are already underway, or is it going to take some kind of a crisis, something comparable to the COVID pandemic that will really force the issue and force the kind of dramatic, systemic transformations that we are waiting for?
You are probably right, actually, that we probably will need something to bind us together. But we could also just decide that we are at a starting point at this very moment, at this first church, where we can actually just decide also to make a change. But I also think that in order to go towards this more ecosystem thinking, we do need to work way more together. We tend to think maybe that we can solve things alone, but the only way forward, I think, is that everyone is, that we agree actually on which challenges we are going to solve and agree on how we can solve them and try to work together.
Yeah, I totally, wholeheartedly agree with that. And I also want to say, I was very inspired by Marcus's slide about the ecosystem, where you have the wearable, where you have all these different avenues, and in a more and more fragmented world where social media dominates how patients access, think, feel about their health, what we can do from a healthcare design and policy making and digital standpoint is to create an infrastructure that no matter where their entryway is, whether it's through the Apple Watch and tracking their sleep or through something that they trust, to actually guide them into this funnel of healthcare, and then not to let them down with what you're building in Sweden, to have really the patient experience and the data and what's happening here in Iceland, to actually catch them as they're coming from multiple avenues. Because the moment they're let down, especially the vulnerable patient populations that we've interviewed many of them, where there is this mistrust, this, oh yeah, right, it's just going to be one of these things again. The moment we show them, no, we thought about this, you are actually going to get a warm handover to the next place, and you can rebuild trust. I think that's what will set up healthcare for success. So again, I also see the glass half empty. I live in Germany. We have the lowest happiness index. So, but there's also the glass half full with a lot of infrastructure that's really setting the path forward, and now we need to get people from multiple directions.
Yeah, I also think, the collaboration across sectors is very important. If you call it an ecosystem or a jam session, I don't care. I prefer the jam session allegory, and I think that's really the way forward. We do realize that the current system is not working as it should. It's getting too expensive, so something has to be done. We are operating basically a post-war system of health service, and this does not fit for every purpose. It has been, it was better than maybe than the one before, lack of system basically, but it can be improved a lot, and I have the faith. I mean, there's a lot of church references here that this is actually going to happen, and I do believe that Iceland has really a pole position in letting this happen, and doing things that would be more difficult to do for different reasons in other countries, in other places. Maybe regional Highland is one step ahead than more other regions, but Iceland could have the opportunity of really shaping the situation and thereby creating all kinds of opportunities also for startups and in this sector, etc. So that is something I really believe in. Of course, partly because of the pioneering work that was done in decode genetics here just somewhere. I don't know, I've lost my direction. But that is something I really believe in.
So if we could go a little bit into specifics about that, I sense that we kind of agree that there's something big around the corner. There's something, a lot of change needs to happen, and this is a global challenge. But you have also mentioned, several of you, that we have opportunities in Iceland. So could we focus a little bit on that? I mean, what are those opportunities exactly, and how could we best achieve results by using those opportunities?
I agree that Iceland can be the European, at least, trailblazer in this area. And that's based on one of the opportunities that is already in place, and that's the data. You have huge amounts of data where value has not been leveraged yet. So it's still siloed, but at least it's there. And you can combine it, and you have a finite population where trajectories can be traced to understand how things interact with complex modeling or simple modeling. But that's an untapped source of opportunity, or it's not untapped, but there's much more to be tapped. And that's where also the startups come into the picture. How can they contribute with their pieces to this more holistic picture of, again, ecosystem seems to be the word of the day. But so that's my obvious first opportunity.
Yeah, no, I just want to add to that the work that we did with dialysis patients at Landspítali was really eye-opening for me here in Iceland, where I was told, well, it's not just the hospital. Any of us who have any issues would also go to Landspítali. So that circularity of well, we're not just designing something for the other, but it's actually for us. And the connectedness between people, it's like, oh yeah, here, like we know each other, is just something that creates like an ecosystem that is very unique that you have here, where in Germany or also in the US, two places that I experienced the most, there's more kind of this, like, oh yeah, this is kind of the other. And I think that piece will just allow you to innovate in a context that I think will propel you forward, as long as you also have a lot of forgiveness when things don't work as well, to still stay the cohesive like part that holds you together and really propels you forward.
But what's the best way to design solutions around like this huge bulks of data? You've been consultants, Shirin and Barry, you've both worked with companies advising. What's the secret sauce of, you have all this data and you need to figure out a good way to utilize it? How would you go about doing that?
I think a lot of it is what I mentioned in the talk, to really take a deep look at what is the context. And what we do when it's very complex is we actually tease out the edge cases. So we would look at vulnerable populations, for example, in mental health, or vulnerable populations in the aging population. And then we would look at like clearly defining where are areas where we can actually make our first step while still managing the risk. So looking at like where are pockets within the healthcare system where we can actually have a little bit more buffer, so not the areas where people are stretched thin. So we often find that acute care emergency room is not the best place to start unless it's particularly about that area. And then to really kind of like tie in this perspective of like, okay, what's actually going on, and then leveraging models that are out there. So what we found in Europe is that the work with HIMSS has just been incredibly impactful, and also the fact that you can kind of like baseline and then use design thinking as ways to really push forward and say, okay, so how do we now understand the patient perspective, the provider perspective, the family caregivers? They're often not included. It's like the free care that shows up on no balance sheet. Like, how do we include these perspectives? So it's the big picture and then kind of like strategically honing in. And the only way to strategically hone in is, again, cross-disciplinary, so not just looking with one department or one area, but I mean, we're seeing it today, right? I mean, this conference is hosted by 2 ministries. How often does that happen? Like, that's, for me, just amazing cross-disciplinary and interdisciplinary work.
I would add to that, and if I could go back to your previous question, it seems to me that Iceland is in a position to be a laboratory of the future. I mean, partly for the obvious reason, you're an island. It is a relatively self-contained, relatively homogeneous population in which you have, as Shirin just said, you've got people here from the startup community, from the professional community, government ministers. There's like an ecosystem in one room, as it were. And I am obvious, so going back to the glass half full, the Germans, the glass is always half empty. I'm from Silicon Valley, so our glass is always half full. And everybody who's creating, you know, the next algorithm to figure out how to place an ad on a website thinks they're going to change the world. But somewhere in between there, well, I guess what I wanted to say is the U.S. system is now on the verge of collapse. Our own government is at war with what had been until about 1.5 years ago, probably the most advanced biomedical research apparatus in the world. So the mantle is being ceded to somebody else, and I don't see why that couldn't be Iceland.
Yes, Iceland as a test tube economy. That's
yeah.
That's I think that's actually something that could be worked on and seen as an opportunity. Absolutely. But I wanted just to mention that, I mean, already in the researchers' circles, Iceland is leading the field in genomics. And I was at a meeting a couple of years ago with researchers and administrators from Qatar, and one of them announced that Qatar wanted to become Iceland of the Middle East. They didn't know I was from Iceland, but this is what they said. So I just wanted to mention that.
I also think that we can become way better at sharing data for research purposes, because that's also a huge opportunity for us. A lot of researchers, when they get a research grant, they spend a large portion of that grant in collecting data. But we have a lot of data. If we would just think smarter, not harder, harder, not smarter. If we would just use that data that we already have in a way that it could be shared, of course, without any personal identification and so on, maybe we could create digital twins of that data or do something innovative, then the research money within Iceland could also be used in a way more strategic manner to get way further. So I think we can also elevate research by sharing healthcare data in a smart way. I'm not saying I have any kind of solution for it. I think about it every day, but I think we could do that together.
But Marcus, you touched on that point in your presentation that obviously there's tons of data lying around in the cloud or wherever, but it's fragmented. It belongs to some department or a hospital or whatever. What's the secret sauce to get people to share data, and how can we achieve that goal?
Well, one is financial incentives. So, for example, if we want to, bad quality drives costs. And those costs appear in parts of the ecosystem where quite randomly if you don't look at the systems level. So one very important part of this is the movement of culture, understanding that we are all in this together. It's not primary care and hospital care, it's patient care. And no one goes home from the work or leaves the jam session before everyone is finished. So, which means that the patient fared better. So that means that planning needs to go together, be done together with endpoints or outcomes that are mutually interesting and mutually important. And that all stakeholders, private enterprises, private providers, public healthcare, understands that my part in participation and my part in the provision of that value is this. But my part is also making sure that the others can do their job well. And you cannot have this kind of culture or environment if you don't have transparency over organizational borders or knowledge borders or whatever borders you manage to build over in this post-war setting that we're living in. So transparency and culture is like part of the secret sauce on top of the data.
Yeah, on this point, I think what is absolutely needed is the correct regulation. Nothing is worse than operating in a regulation vacuum. So I think the European Health Data Space regulation is partly addressing this within Europe, and Iceland is part of Europe, and at least in that sense. So it applies as well here. It entered into force beginning of this year and will be gradually introduced over the next 5 years or so. That's my point. So the regulation has to be in place to allow this to happen in the right way, taking care of all the different issues that need to be taken care of.
And the European Health Data Space is there to address exactly this problem. Yeah. So if I have one recommendation to Iceland, get the most out of EHDS. Read the messages between the lines in the pre-work of the legislation, because it's there. This is exactly what the legislators in the parliament wants to see happening. But you can always interpret law in different ways. So get the best legal team working, saying what are the opportunities appearing with EHDS and use those opportunities.
Anna, I don't want to put you on the spot, but you have two ministers here. You've been working in this field with data and healthcare and so forth. What's your ideal scenario? What do you want to see happen? If you have any message to the ministers, what's the best changes that we can make right away to get things moving?
I think if we manage to share data in a meaningful way, and if we manage to continue working together, it's actually been, and that's also maybe the amazing thing about Iceland. Iceland is also small, so we can actually work together, and we can do incredible things if we just manage to work together and find a solution that works. And I'm a strong believer in always having the patients with us, because then we are also solving the problems that are actually the problems of the patients, and trying to create a new type of healthcare would be really meaningful for Iceland, and we could actually prototype it and just test it out.
Barry, I mean, you have your background in academia. Do the Icelandic universities have a role in this mission?
I think that the opportunity for Iceland to position itself as a laboratory of the medical future is very real. I think it sounds like I'm trying to flatter you or something like that. But,
very flattered.
why don't you just accept that as everybody is commenting on how things are changing at the rate of change is unprecedented in human history. Probably more fundamental innovations in the last decade, not just in any previous decade, but maybe all decades put together. So nobody has anything approaching a map of the future, and I see no reason why experiments cannot be conducted in this compact, relatively homogeneous environment that could help us create that map for all of humanity.
Do we, I mean, you've been working on in the university and a course where healthcare professionals and other kind of professionals work together. Do you see, and others can jump in, do healthcare professionals need different skill sets in the future than they do now? Do we have to think about these things in a different way?
Yeah, I do think so, and that's kind of why we started the digital health program and also the innovation line that we have been driving within the hospital to try and teach everyone how to co-design or engage in participatory design, because actually the healthcare professionals are the key to unlocking what needs to be done in a different way, because there's also a lot of invisible work within healthcare. So a lot of work that is being done just to copy this paper in order to put it here and so on and so forth. So there are, I mean, we could make it more meaningful how people are engaging in work, but in order to do that, the healthcare professionals need to be the designers of their own future.
Yeah, so drawing on that, one experience in our setting has been that, well, doctors don't need to become data scientists or economists or learn law, but they need to be able to speak with people who know these things. And the first thing that happens when you do a jam session, for example, is that even if you try to speak about the same thing, you don't understand each other, even if it's all in Icelandic or English, because there is law Icelandic and economics Icelandic and medical Icelandic. So they don't really truly meet. And that's, so it takes a time to build those multidisciplinary understanding teams to cover all bases. So And this is not done overnight. It's a matter of trust, understanding each other. And again, I also believe that Iceland can be the European and global trailblazer in this, because if you go to the United States, I've been a lot in Silicon Valley working with Berkeley and Stanford. Once you gather around the bonfire and the problem is solved, people run away again. And that value that was created around that bonfire needs to be transferred to the next problem and next problem, because it takes so much time to build those environments. So if you succeed to build those environments where people understand each other and trust each other, then you're halfway there in the next project and the next initiative. So building solid teams, culture, building buildings like these, where startups can meet with clinicians, hopefully, and academics, and just evolve over time and let it take some time. I think that's really valuable.
And there are some tricks that can help you do that. One of them is look for hierarchies and do whatever is possible to dismantle them. So I noticed one of the slides, and I think this follows from your point exactly, one of the slides that Sharon showed was of a group of people at, doing the Post-it thing, and one of them was a nurse and one of them was a surgeon. One of them may have been an ambulance driver, one of them may have been a pharmacy assistant, and hopefully one of them is a patient.
There was someone from the patient, patient advisory
Don't forget,
council. Yep.
And a patient's family. So it's a recognition that there are multiple stakeholders. They are not all bringing a shared expertise, but each of them has an expertise that needs to be respected. And it just so often happens that, you've got a surgeon and a nurse in the same room. Who's in charge? And that's the kind of thing that can be dismantled in the interests of comprehensive solutions and well-functioning, integrated, multidisciplinary teams.
And to add to that is also the judgment that comes with it. And what we've seen in cross-disciplinary teams is the self-judgment. Oh, I don't know enough, so I'm not going to share. And the second part is the judgment when someone makes a mistake, uses the wrong word in the wrong context, and kind of mixes something up. And if we can take a step back and be a little bit more forgiving about, oh, you don't come from this area, it's okay, describe what you mean. And really, to your example, not think of it as like one language, oh, we should be all understanding it, but really about like, yeah, we need translators, we need help integrating, and then the courage to step forward and try things out. And I did some work in China where with the Post-its, we had to have them all in the same color, all the pens in the same color, so that nobody knew who higher up in the hierarchy put down the Post-it, because then the others would just copy exactly what was on there. And what we really need is kind of that diversity of thinking. The folks at Stone Yamashita Partners, they have the story of like, it's like a high rise. You need the person on the top who sees far into the distance, but you also need the person who has the mezzanine floor and who partly looks at the grass, because they can tell you on what's going on in the soil. And you need to have all these different perspectives and match them together, and the wisdom to not think one is better than the other.
Marcus said that the medical doctors don't need to become data scientists, because we also have data scientists to take on that task. It's also a dwindling workforce, the medical doctors, also because of early retirements. But what I wanted to add to this discussion is that in our networks there have been some analysis and discussion also with the authorities responsible for education to look into curricula for medical doctors, for example, to look what can be updated, modernized, and there's a lot that can be modernized there. But also look into, is there an opportunity for new types of jobs to be created, to take on those certain tasks that need a specific education and background to do properly. And it doesn't mean that every medical doctor has to know everything. And I mean, that was in the old days. They knew everything. Today, you go to the doctor and you already consulted with Dr. Google what's your problem, and you will tell your doctor what your problem is, and that's the real world today. So new jobs, opportunities for new types of jobs, that's something that universities might look into.
I want to add one quick thing about the doctors becoming the innovators. Startups, be careful. If you have just one clinician on your team, you're also just getting the perspective of one. And that can be incredibly biasing. In fact, the first case study that I shared with infectious disease specialists, there were actually multiple infectious disease specialists working as advisors to the company, but nobody had spotted that they wouldn't be receiving the reports. So it stays on such a high level that it's not the excuse to then not go into the context. So make sure that you have the input because they deliver very valuable information, but then also do your homework.
And it is definitely more difficult to have multiple people involved, but it's also so valuable. So yeah, definitely.
Do you have any advice about prioritization? I mean, there are a lot of projects that we could jump into, but how do we prioritize? I mean, resources, time, money, it's all scarce. Staff, healthcare staff are overworked, they are stressed. So how do we prioritize which improvements, which innovation, like how do we go about that?
Yeah, one tool that we use with our clients, with organizations, is the 2x2 of resources versus impact, where you basically say, how many resources do you need to do each of these ideas? How big do you think the impact is? This is where the Germans get tripped up because they're like, we haven't studied it. And we're like, gut feel, just gut feel, like where would you position this? And then the question that often kind of pops up is like, oh, there's this idea, it's super impactful, it doesn't need many resources, but like, it's like, it's not as impactful as something else, but we can do it quickly. To then have the courage to say, okay, if it's a little impactful and it's super easy, maybe it fits into one of these times where the team is not as busy, so just do it. And don't hesitate and wait for the permission to be able to do it. And with that, to have the conversation, and to not have the conversation alone, but again, in interdisciplinary teams, where you get the different perspectives to actually decide how impactful is it, for whom, does it cover all the audiences. So that's just a very quick way of sitting in a jam session and not letting people leave until they have sort of placed down where they think this would go.
And also, I think we need to remind ourselves that innovation is a risk investment, so you can never know beforehand that you get the impact that you wish for. And you're, if you're the innovator, you're deeply biased in expected outcome. Sometimes I think in terms of think big, start small, fail fast. So you can go to the next. And failing is a learning experience that is very valuable, as you said in your presentation. But when we look at prioritizing public investment in innovation, we also value potential scalability because there's no lack of good ideas. But if you have constraints, if you have bandwidth that only allows supporting a certain number of investments or innovations, then you need to, preferably in a fact-based or even data-driven way, understand what will make the largest impact. So actually, fact-basing, is that the y-axis or x-axis or y-axis? I don't remember. But making that as plausible as possible based on the information that you already set on.
And maybe there could also be like small seed funding for doing something wild and crazy, and doing some research project or a pilot project that doesn't necessarily have to lead to a big change, but can be one of those small changes, and some of them will lead to the huge changes. So that could be one way, because research funding in Iceland is also incredibly scarce. So that could be some small projects.
So we are running out of time, but I would like to ask Indriði about personalized medicine. obviously a hot topic in Iceland right now. The government already put out their policy regards personal medicine recently. What do you advise to be the next steps here in Iceland? How can we achieve what we want to achieve as quickly as possible?
I'm gonna, because we are reaching the end of the session, I will keep my inputs short. I could give a 2 hours lesson about this, but I'll refrain from that. Also because I learned today from Barry that you should not be afraid of mixing metaphors. And somebody who was very good in mixing metaphors was William Shakespeare. And I think I will refer to his words, what we need to do. We need to take arms against the sea of troubles and by opposing end them.
Okay, great last words. Can I ask everybody to give our guests a good hand? Thank you.